Hey everybody. Hey everybody. Happy Friday to everyone. We are so excited for this conversation that is going to come forth. We are very, very excited to have Dr. Alton Dyson here to talk about staying prepared. And that's just a little spin on the conversation that we will talk about with PrEP. So, because she is very qualified to give you this discussion, I'm just going to let her introduce herself and kind of talk about the work that she is currently doing now. And that will just give us a little insight on why we are excited to have you here today.
Perfect. Thank you. Can you hear me okay?
I can hear you. I can hear you fine.
Awesome. Very good. So I'm so glad to be here. So as Crystal said, I am Alton Dyson. I am a pharmacist by training, so I do have a PharmD. Graduated from University of Tennessee in 2013 and then completed a residency in 2014. And that's really when I focused in on HIV care as well as PrEP care. So really managing treatment for patients who are living with HIV, but also looking at ways and methods for people who may be at risk for HIV acquisition. So providing those prevention methods to them. So that's really kind of how I got into this work. And then now work part-time at MAO here in Montgomery, Alabama, and then also work for ViiV Healthcare. So it is a pharmaceutical company that actually makes medications solely for people living with HIV and people who could benefit for PrEP. So that's kind of the work that I do now and enjoy every minute of it. So that's a little about me.
Yes, and so guys, you can see she is very qualified to give us this information. But if you're watching now, I see a few people that are on. Make sure you share this live with anybody that you can think of that may need this information. It may be beneficial. It may save someone's life. It may be able to make sure that you may change the trajectory of what you have going on in your sexual health or in your personal life. So what she's going to do is just give us a little breakdown. We talked a little bit about it earlier this week, but she's going to give us like the medical side, just the true definition, what PrEP is, how it's used, who qualifies for it, and briefly maybe like some general side effects that we could look forward to. And then if we have some questions, we'll definitely take those. I'll try my best to approach the questions and make sure that I'm catching everything. But I'll go ahead and let you take it away and give us the information.
Perfect. Thanks. So, yeah, so what is PrEP? That's a really good question. I think there's still like a lot of misunderstanding or misinformation about PrEP out there. So glad to be here to share. So PrEP, it stands for pre-exposure prophylaxis. So meaning pre, before exposure, obviously before any exposure, and it's a prophylaxis or a preventative medication. So that's breaking it down to what it actually means, kind of, and like I like to say, like, so without all those fancy words, it kind of breaks it down into layman's terms, if you will, of what it means. So, who could qualify for PrEP? I think really anybody who feels that they would want PrEP should definitely be offered PrEP, and it's something that would be of value to them. And so that's the first thing. I think that's something that we have oftentimes kind of missed, in that, like, we focus so much on, what behavior does someone have, or this, that, and the other. But no, it's really about, if you want to prevent and protect yourself, prevent the possibility of contracting HIV. Definitely, it's something that could be right for you, and so it would be important to have that conversation with a healthcare provider or someone who can provide that to you. But then, in terms of kind of maybe what something, some of the criteria from the CDC, they do kind of define, at least what someone maybe at high risk, and I really hate that word. I hate the word risk, because
I
it
know.
sometimes can have a negative connotation, right, Crystal? And so,
Right.
I hate the word, but obviously in the healthcare field, we use it to kind of help guide clinicians to understand maybe what the risk could look like. So, um, that's definitely really before there was, guidance around if someone has, unprotected sex, or condomless sex. We like to, use that terminology as well, instead of unprotected, right? Because condomless sex doesn't mean, if you're on PrEP, it doesn't mean that you're not protected, right? So saying condomless sex, then, kind of brings in the fact that you could be taking PrEP and still protecting yourself. So someone who,
Mhm.
regularly wants to have condomless sex, or, does have condomless sex, could definitely be a candidate for PrEP. And then I think, there are some other demographic things to think about, right? So when we think about the risk of HIV, and like where the epidemic is greatest, for the last couple of years, the South, the US South, has accounted for most of the new HIV diagnoses that we see across the entire country, over 50%. And so sometimes thinking about just demographically where you are, and, social circles, right, who you're running with. And so being in a space where the epidemic is highest automatically puts anyone really who's living in that area at increased risk, right? Because you're in an
Absolutely.
where there's a high prevalence. Um, the other thing is thinking about, looking at the epidemiology of HIV, right? And so we know that MSM, so, or, we define that as men who have sex with men, are at higher risk of contracting HIV. We also know that, looking at epidemiology, Black women tend to be highest risk, or higher risk than others. And so, just to kind of put it into perspective, especially talking about women, because I think that's a big focus here, is, I'd say, I think the last information that came out was maybe 2019. It was about 25% of the new HIV diagnoses were in women, and 75% of that 25% were Black women. So Black women
Wow.
have the highest number in terms of women who were newly diagnosed with HIV. So, thinking about that, is that a reason that maybe PrEP might be right for someone? So there are different things to think about, a lot of information to think about when you're deciding. But again, I always go back to assessing personally um, your sexual health, and then also what you want out of your sexual health, and then making that decision and having a conversation with the provider about whether PrEP may be right for you.
Absolutely, absolutely. And that was one of the things that I was going to talk about. You said a lot about the risky behaviors and saying that terminology, and just really the numbers reflecting African American women, that we don't necessarily know about PrEP. And I was just wondering, what was it, a pushback, or was it just that we simply did not know about this preventive measure?
Yeah, that's a good question. So, I'm actually in the process of doing some research, particularly around PrEP with Black women. And so, part of that research and part of what we did was looking at some analyses from before and some research before, where there were focus groups that were held with Black women to really understand, like, what's the deal? Like, why not use PrEP? Why is there this pushback? What is it? And so it tended to be multiple things, but I think two of the biggest things that came through was the fact that one, lack of awareness. So I
Mhm.
specifically remember a study or survey. It was a survey study that was done at Essence Festival. Everybody's familiar with Essence down in New Orleans,
Yeah,
and they had Black women stop, fill out a survey, and a good portion of the women actually said they just had never heard of PrEP. And that makes a little bit of sense because prior to, I think we're doing a better job now of, I guess you could use that word, marketing to other demographic groups. But part of the reason Black women said that they didn't know about it or didn't think it was for them was because of the campaigns that were being run, the ads that they were seeing. It didn't have anybody
very
that
true.
looked like them. So, like exactly what she
Very
said, a lot
true.
of looks like me. The ads didn't look like them, so they didn't think it was for them. You know,
Right.
that was
Representation does matter.
matters. And so I think that's getting better because we heard, people heard that loud and clear that when there's a flyer or information that's out there, it really needs to look like me for me to understand that this is for me. And then I think the other piece was just somewhat fear a little bit about, the medication, taking something that, um, I'm not sick, so why do I need to take something? I think that always is, a factor. And I think we have to also, recognize and acknowledge medical mistrust and distrust, right? It's
Yes,
not
that was part of it because that was you think about the COVID-19 vaccination, and I was just wondering, was that part of it? But when I really think about it, me being in the healthcare field, if you're not directly into HIV awareness and prevention, is really not something that is really discussed. So we do have some comments. I do want to acknowledge that they're saying that they don't know about it. Most heterosexual people don't know about PrEP. So just kind of in line with what you're saying. So
yeah.
guys, you still have opportunity to share this because I think this is a great conversation that we're having, and we're ready really to answer any questions. So if you want to continue on that road, we can. If you want to get into the different types of PrEP, so we can understand which one would be most beneficial for each individual that may be present tonight,
Yeah,
if that's
absolutely.
something they're interested in.
Yeah, so I'll finish up kind of just with that piece because I think, there's other just a few more points kind of to make in that. We talked about the lack of awareness. We talked about, not a little bit of a fear, but I think another big theme that we kept hearing was I'm not at risk. Like, so this lack of understanding what risk means, and risk is subjective, right? When you think about it, which is why I don't really like that term. And like I said, it has a negative connotation as well. So it's like, oh, risk. You mean I'm doing something that would put me, make me, bad or something like that. And so it just has this negative connotation. So people tended to shy away from that as well. And that's why I think when you and I talked about I like to approach PrEP from the perspective of empowerment, right? So it empowers
Yes,
me or whoever to take control really of their sexual health. And so now it gives you that sense of control because this is something that is for you. You decide to do it, you take it or not. And you don't have to you don't have to share that with anybody. It can be between you and your provider, and you're protecting yourself, and you have that control and that power, and you're empowered to do what's best for you. So I think that's one of the things that I wanted to bring out, at least in that conversation, that it's not about risk or you've done something wrong or things like that. It's really, to me, about empowerment and taking.
right. And I can see how people would look at themselves and say, well, if I'm taking this, then I'm admitting that I am promiscuous, but that would not even mean that. That may be something that they take on themselves and they end up owning it, and that's really not the case. So really changing the narrative, like you said, being like you're in control of your health. And so I think that is very brave and big of them to overcome those thoughts or those self thoughts that kind of give a negative spin to it instead of spinning it to that positive narrative. So that's a good point to bring out. And then we did have a comment that said when people talk about sexual health, they seem so sensitive and embarrassed. And I can get that too, because it is intimate, between a partner. And so those are some things that you may not want to share with the public. So at times it may seem to be like an embarrassing situation, but it's just because it's really intimate. But I don't know if you want to comment, according to that too, to that question.
And I totally understand that. I think that's a fair statement, a very true comment. I think also, some healthcare providers are uncomfortable, right? Because that means they have to actually have a conversation with you about your sexual health. And so sometimes that can be uncomfortable for healthcare providers as well. And so they may not share that PrEP is available, and they may not know that PrEP is available, but they may feel uncomfortable even asking because they don't want to come off as accusatory, right? Of accusing you
Right.
promiscuous. That's the word that you used a few seconds ago, or that you're out there, whatever it is. And I
Right.
wanted to comment on that word and that thought process around that somebody is promiscuous. I'll ask you to see if you know. I hate to put you on the spot, but I'll ask you the average number of sexual partners that a woman who gets diagnosed with HIV. What do you think the average number of sexual partners is before she's diagnosed?
I mean, just realistically, when you think about, your own, I mean, it could probably be anywhere from 3 to 5.
Two. So think
Two.
about that. The
Wow.
average number is two. And so
Wow.
it's like it's not that high.
Because it really only takes one.
Right. It's not a promiscuous person, right? I don't think we would any
Well,
think that.
and I wasn't saying it for people to feel like, I'm just saying their own personal thoughts in their mind.
Right, right.
And
Yeah, yeah.
yeah.
And no, I wasn't thinking that you were saying it that way, but it was that
Yeah.
we hear that a lot too, in terms of like that not understanding like the risk and associating risk with somebody who's just,
Right.
there and
Yeah. And we had a comment that someone they put 3. So that's some good information to know that 2.
two is the average.
Lucretia said, "Woo, child, God has been with me."
Exactly. So it's like it makes you think, I think, right? Like that too. Wow, okay. And then you just pause and you think about that yourself, and then you make your own determination and your assessment on whether or not now maybe this might be right for me. This might be something that I need to consider and think about, right?
Exactly.
Um,
Exactly.
yeah. And then this is the last thing I'll say on that, and then we'll start talking about the medication. The other piece is that what we've also learned is that in terms of women, the risk is really more so associated not with the woman but the partner that she has. So a lot of times that partner, may not be in a monogamous relationship. The woman is clearly maybe thinking she's in a monogamous relationship, or she may know that the partner is maybe seeing other people, but they don't associate the fact that if the partner is with other people, when they come back to you, you're also with those other people. And so understanding that a lot of times for women it's not about the woman's behavior, it's typically about the partner's behavior.
And we do talk a lot about that on our team, and saying that it is not always about you, it's about your partner. And if you are knowing that your partner is unfaithful, that is one way to bring the control back to you, because sometimes females are not ready to leave everything and with hope that things may get better and things may change. And so that does, I know use that word, but put you more at risk for being, coming contracting HIV. So that is true. We talk about that quite a bit.
Yeah.
So
So yeah, I promised that was my last comment, and I would leave that subject alone, but I wanted to make sure we got at least some of those key points out there. So in terms of
yeah.
medication, there are actually now 3 options. Before, I would say before earlier this year, or at the end of last year, before that, there was only two options. And so we'll talk a little bit about that, but now we have three. So that's wonderful to know. So the first, probably the one that maybe most people are familiar with, is something called Truvada. It's a oral pill. It's blue. A lot of times we referred to it when it was the only thing, the little blue pill. And it was something you take once a day, every day. I liken it to like birth control, right? So, you take a birth control pill and you take that every day. It's for a preventative method, right? It's preventing having children. And so then in terms of, prevention for sexual health, Truvada is a pill you would take every day. That could be used for men, women, transgender men, transgender women, just anybody. So it's open for anyone, and that's because it was studied that way. It was studied in multiple populations, so different demographic groups. In terms of another pill that's an option, it is Descovy. So Descovy is for men and it's for transgender women. It was not studied in cisgender women or women who were born women. So it does not have an approval to be used in that patient population because they did not study it. The makers of that medication did not study it in cisgender women. And then the last option, the newest option, is an injectable, and it's called cabotegravir. It's the scientific name for it, but it's marketed as Apretude on the market, and it's available for anyone. So it was studied in all populations, so men, transgender men, transgender women. So it has an approval.
Well, and I was going to say, not to be confused just because you're taking PrEP, that it is going to help against other STDs,
Right.
correct? Just okay, just just with contracting HIV. Now, the ones that you mentioned for the women and for everybody, was that safe for women that are that were pregnant or expecting? Because I have attended some trainings and just questions how safe it is for that.
Yeah, so currently the only one that has enough data to really, and they have studies to show, is going to be Truvada. And it's because it's been around the longest, right? So they've had the opportunity to study it there. The newest one, the injectable that I talked about, Apretude, they don't have enough, I guess, data to make a determination yet to say, yes, you could use it in pregnancy. And reason being, it's just coming fresh out of clinical trials, right? So, the clinical trials started back maybe 5, 6 years ago. And then now you can see how long it takes really to get to this point for an approval to assess the data and all of that. And so if you are familiar at all with kind of like the laws and things that change really around kind of some of the misuse and mistrust that was built in clinical trials, that women are considered, or women who are pregnant and children are considered kind of a protected group of people. They're special population that we don't like to test in. We test in like a general population first, the healthy individuals, that sort of thing, just to make sure that we don't do harm. And then in terms of getting the data to support for Apretude going forward, what's occurring is that sometimes, often in clinical trials, people do become pregnant, right? They're of childbearing potential, and so they become pregnant, and so then they are followed until the end of pregnancy to see if there were any negative effects. And so once enough of that data accumulates, then they can make a determination. But right now, Truvada is the only one that you can see that has a recommendation that you can use it.
Awesome. We have a question. How does the injection work?
Yeah, so that's a really good question. So I'll kind of talk about it, and then if I hit all of the points about what you wanted to know about how it works, then great. If not, there's something more specific, you let me know. So, in terms of how it works, you first have an oral lead in with it, right? So, meaning there's an oral medication that you take for 30 days first. And that's not to get any like drug levels or anything like that. That's really to make sure that you don't have an adverse reaction to it, right? Because you give an injection and it's a long term injection, it's in there. And so, if you have a severe allergic reaction or something like that, they can take it out. So, that's why they give you that oral lead in first to make sure that you don't have an adverse reaction to it. And then that's for 30 days. And then at the end, or 28 days, whatever the provider decides. So somewhere around a month, you get that. And then at the end of the month course, you come in and you get an injection. And it's a deep IM injection. So kind of, the same injections when you get them in your hip, right? So you get something in your
Mhm.
hip, your glutes there, and it gets deposited there. And so what it is, the reason it's long acting is it's kind of like a little medicine depot that kind of sits in the area and it releases slowly over time into the system to give you the levels that you need for protection. And then you get it
Awesome.
that injection every 2 months. So you get
Okay.
yeah get it six
So,
times.
so for all my, go ahead. I'm sorry.
I said it's every 2 months, so 6 times a year to get the protection against HIV.
So that would be really good for the ones that don't like taking birth control pills, or how you compared it to that. It would be for the ones that have a hard time with taking pills. So that is pretty much a game changer. We do have a question. Okay, I've read some research on this. Can you talk about some of the side effects? So I guess before we get into the side effects, you pretty much said who would pretty much qualify. Is there a reason that you would not be a candidate for any of these, really, or the injection?
Yeah, so I mean, for any of them, really, the only one right now that we would say you probably wouldn't be right for you, I'd say it in terms of like the Truvada or the oral medication, the one from before, it does have a cutoff limit really around renal function. So, like if it's somebody who has some kidney issues or things like that, may not be the right option for them. Obviously, you'd have to do like tests, right, and get labs to see where that cutoff is for them and if they met the cutoff point. And that would be a decision and that a clinician and the patient would make together, right? They would look at that and the clinician would advise yes or no. So that's kind of like the major one, I think, for Truvada. Obviously, somebody who knows that they're not going to be able to take pills every day, it's not going to be right for them, right? Because what you run the risk of is developing resistance. So, should you take the medication and you take it kind of sporadically, not regularly, and then you do come in contact with HIV, then you run the risk of now that HIV virus knowing that medication.
Wow.
Then when it was if you then became positive and needed to go on treatment, you wouldn't be able to use the Truvada for treatment. And so that limits your
Wow.
options for treatment. And so it's very important that if you choose to take the oral medication, you take it every day and you don't miss any doses. So that would be another kind of reason that somebody wouldn't be a candidate if they know they're not going to be able to do that. Like I'll be honest, I'm not a candidate for that because I could barely, when I was on birth control, remember to take it. So I was like,
Right.
that's not going to be an option for me. And I'm upfront and comfortable saying that because I know my limitations, right? Um, and then I think the other thing in terms of the injection, it's similar, right? Like if you know that you're not going to come in, you're going to miss appointments and visits with a provider, then you wouldn't want to take an injection. And so maybe it is that taking a pill every day is right because it's something that you're control of at home and you don't have to go into a clinician's office because the injection you do have to go in for a clinician to administer that to you because
Right.
I don't know, it's
Awesome.
kind of difficult to get around there and give yourself a shot in the hip yourself. So, yeah.
Awesome. We would like to welcome Miss Marie, watching from Charlotte, North Carolina. Thank you for tuning in. Another comment from Lucretia. She's saying that you can't take it if you're HIV positive.
Correct.
Correct.
Yeah.
This is if you are. I think of course they test you first to make sure that you are HIV negative before you can start PrEP. This is a preventative measure to make sure that you are not. If you come into the contact with the virus, that you will remain HIV negative. Do you know the percentage of how effective it is?
Yeah. So, um, obviously, we look at it based off of the data from the studies. And so it's anywhere between, based on the different studies, like 97 and 99% effective, somewhere in there. For like the oral medications, I will say that the data that just came out for the injectable, it was shown to be superior, statistically superior to the oral medication. So it actually outperformed the oral medication, if you will.
Oh,
Is
that's
kind of
good.
a way to say that. So yeah.
Definitely a game changer. So I think really, it you really hit all the questions. Do we have any other questions that someone may have about this information? She gave us the three options that you would have. Ladies, you have two options just because you were included in those studies. You have your side effects. Your doctor, your healthcare provider would be the one to monitor your lab work periodically to make sure that everything is intact. Yeah, she hit the side effects. She talked about kidney concerns and that they will follow up the lab work. Is there like an initial side effect when you first start taking it? Like, do you have as it gets in your system? Are there any side effects with that?
Yeah, so for the oral medications, I can tell you for sure that a lot, some, not a lot, let me not say a lot, but what we do here is, sometimes nausea, upset stomach, because you think about it, you're introducing something into your gut, into your stomach that is different, it's new, it's foreign, and so your body is trying to adjust to that. That usually maybe lasts, a week or so, and then folks are usually okay. The other thing that people typically do is eat with it. If you put something on your stomach, kind of coat the stomach lining, then it doesn't have the opportunity or as much of an opportunity to kind of irritate that stomach lining, is what's kind of occurring there. In terms of that, and that's for the two oral medications. In terms of the injection, I think if I asked you all, you probably could answer that question for me. You get a shot. It's not always the most pleasant thing. I don't think people are lining up saying, "Give me all the shots. I'll take them all." There is that injection site reaction, most commonly being pain, that is associated with the injection. What I can say from reading the studies and looking at the data is that report of injection site reaction, particularly pain, decreased over time. So, it was highest in the first injection, and then it decreased over time after that, because I think, we could say most people at that point, you know what to expect. You come in for your first injection, you're not quite sure what to expect. And then as time goes on, you do know. And so you also learn kind of how to modify, deal with that pain. It's kind of like when you get a flu shot or something like that. We always say, work your arm, keep moving it. Don't let it just sit
Right.
still because it'll get stiff. And it's the same way. We say, keep doing light to moderate activity after you get that injection to prevent kind of that pain and kind of get that to subside sooner. So that's kind of like the biggest side effects that you can think of. Obviously, there's more that are in the package insert and in the label that are reported. But we go through a whole long laundry list of those if you wanted to, because the thing about that is that everything has to be reported. So if
That's
somebody
right.
in a clinical trial reported it, they could say that they stubbed their big toe and they hurt their foot, and it gets reported. So, and it may not actually have anything to do with the medication. So, you'll see that a
Correct.
lot of
Correct.
times in the package inserts.
But I will say, if you are taking the medication and you do have some side effects, it is always a good idea to report those side effects so that, especially in African Americans, so you can see how the medication does within our system. And so I would not shy away from that. Same thing with COVID-19 vaccine. If you're having side effects from that, it's always a good idea to report those side effects. So we do have a comment that says you are extremely knowledgeable, and you are. And so we're so excited to have you here. I don't have any more questions, but what I would like for you to do is to come back and talk about some other topics. Since you're, really, really in that world, what really needs to get out to the community. So we would love to have you come back, talk about some of the studies that you've been a part of, talk about other medications that are beneficial to those that may be HIV positive, or their first steps if they've just newly been diagnosed. Just giving us some information that we can put out to the community. We would love to have you back to discuss those things, have you come to some of our events as well. And you can kind of help us get us started. We are really excited. If you have not heard about St. Paul, this is good information for our community. Yes, it is. We are definitely into the education, definitely want to bring more awareness about PrEP and we have been approved to start HIV testing. I want to talk about our event that's coming up in March 5th in Selma. It's going to be a Women's Wellness and Empowerment Summit. So we'll talk about all of that. We'll talk about breastfeeding, talk about sexual health, HIV awareness. There will be testing to take place, as well as COVID vaccinations and COVID testing. We will have multiple panels with women on that panel talking about that. I invite you, if you are available, you want to do something like that, Dr. Dyson, you are more than welcome because you are very knowledgeable. But we are just inviting everyone that's watching tonight just to kind of put that in the back of your mind. March 5th, Selma. It's going to be inside the Bridge Crossing Jubilee. And so it will be a wealth of information. We're going to have a good time, but we're going to feed you with knowledge as well. And so thank you so much for coming on again. We invite you to come back. I think we answered all the questions, and I'm just excited to see what the future holds for ending this HIV epidemic. So, guys,
Absolutely.
I hope you had a great night. Go ahead. I thought you were going to say something. Did you want to say anything else before we dismiss?
No, I was just agreeing with you. Absolutely. I think that's all of our goal that work in this space to end the epidemic. I think we're all very passionate. I've not run across a healthcare provider who works in, this space that is not passionate about what they do, passionate about the community and passionate about the people that I like to say the people that we serve, because it's not just, being a healthcare provider and, giving information, shoving pills or whatever to somebody. It's really truly about caring and serving that patient population in the community. So, yeah, we're all passionate.
Absolutely. That's right. And you're absolutely right about shoving medication, shoving information. A lot of times we definitely have to work on the behavioral changes, like not just so much, here's your information, why aren't you doing what we told you to do? Just kind of getting to the core of what the real reasons are that we are having to address this and why it's so much more prevalent in our community. So excited to be working with this, and we are going to call it a night, guys. If you are new to this, we ask that you follow She Looks Like Me on Facebook. Share this live because this was a lot of information that went forward on tonight, and we look forward to bringing more conversations in the near future. Guys, have a great night.
Good night.
Thank you so much. Bye bye.
Bye-bye.